Well, thank you very much. Thank you to everybody that got up early. If you're on the West Coast, you're up really early. Some of you will be enjoying this, and I hope enjoying it by recording, but that's all good. And we'll move forward. And I'm sorry about the slightly provocative title. Let me see if I can handle the technology here. Yay. I think you guys can see that, and I'll be the little guy in the corner now. Good. But kicking heart disease in the ass, because it is time to get fired up about finally giving the title of the number one killer of men and women to some other disease. Obviously, I'd like it to be a different scenario where we just generally reduce the risk of chronic illness, disability, poor health span, and enjoy life. But since about 1918, the title every year goes to heart disease in the Western world. Sometimes we battle neck and neck with cancer. We're going to talk about that. But we need to stop that. And we've been very passive about heart disease. It's very interesting. You know, if you ask most people on the street, what do you think more people die of than anything else? You get a whole bunch of different answers. I'm going to show you some data on that in 1 second. But a lot of people will say heart disease. But if you ask them, do you have heart disease? Do you know if you have heart disease? Have you been screened for heart disease? Has your doctor talked to you about your risk of heart disease? Have you ever had any doctor talk to you that heart disease is like cancer and we have to get more aggressive like cancer screening? And most people will look at you like, what are you talking about? Why are you so angry? Well, I'm angry that we don't treat heart disease like we treat cancer. And we've got a lot of work to do on cancer. And we spend a lot of money on cancer. But I challenge you to think about your last visit to your primary care doc and whether kicking heart disease in the ass came up as a topic. So if you just very quickly, too much data here, and this is from, I think, 2016, but if you look what people are searching for on the biggest search engine, you know what it is, called Google. If you go over way to the left in the blue box, you'll see what people actually die from. 30.2%, it's heart disease, number one. Cancer just below, then road accidents, respiratory diseases, Alzheimer's, stroke, diabetes, and so forth. But if you look in the second column from the left, what do people search for in terms of causes of death? Cancer by far overshadows what people are looking for information on in terms of risk of death. And heart disease is that little tiny blue 2% at the top. And then people look at all kinds of other things like road accidents, way out of proportion to the actual risk. And if you go even further, media coverage, New York Times is the third column, and the English paper, The Guardian, is the fourth column. People are reading about terrorism, homicide, suicide as causes of death, almost to the exclusion of getting good, credible information about that tiny 2% that is what people are reading about, called heart disease. I have media alerts when articles come out, and there are underrepresented number of articles that people are reading on, the sites people go to, CNN, Fox News, MSNBC, New York Post, and others. Heart disease gets overshadowed. So we need to kick heart disease in the rear and give up the title, number one. But it's still a problem. In 2019, around the world, still 1 out of every 3 deaths was a heart disease death. Some of that is heart attacks, some of that is strokes, some of that is aneurysms bursting. 18.5 million people a year, 51,000 people a day. That's worldwide. And you can see it's very important, but cancers worldwide are half of that. And then other conditions. Interesting data, but we don't talk about heart disease as a cancer, and heart disease is a cancer of the heart. When you looked in 2020, a year that had a special occurrence called the pandemic, even with all that was going on, with almost all 12 months being involved with people exposed to the pandemic, heart disease was still number one, cancer number two, and COVID, a very serious third cause of death in 2020. Fortunately, that has fallen off dramatically, COVID-19. But that was 2020. And when you get up to 2023, I used to tell people, if you look at the stopwatch to the left, that in the United States now, this isn't the world, one person every 39 seconds died of heart disease. But apparently, the clock is now one every 34 seconds, 2,500 deaths a day in the United States from heart disease. Clearly, number one. And stroke should never be ignored. It is a cardiovascular disease. It may be due to atrial fibrillation or blood clots in the heart or plaque in the carotid and brain arteries, and that's a little less frequent, one every 3 minutes. About 440 people a day have a stroke. So this is the enemy. We got to get fired up. I'm going to try and keep my energy high during this talk. And we have to have a department of kick-ass when it comes to heart disease. And in fact, I appoint all of you, everybody listening, live and recorded. You are now official representatives of the Department of Kick-Ass. We have to really get fired up. And it starts with you, the listener, knowing your heart condition risk and characteristics and specifics. And we're going to talk about that and how this has changed a lot. In my practice, I have a very vigorous practice. I see many new patients and return patients from all over the United States and sometimes from all over the world in my office in suburban Detroit, Michigan, either in person or by telemedicine. And I can tell you there is an unbelievable burden of heart disease that is unknown. It's the ostrich with its head in the sand, and we don't see the obvious. So I'm going to suggest to you an analogy. I'm going to try and carry this through the talk. But why don't we talk about heart as cancer? And this is a growing trend, actually, to talk about screening for heart disease like we screen for cancer. Think about it. You've been to the primary care doc, and they talk about mammograms. Maybe you go to a natural doc, they talk about thermograms for the breast. They talk about prostate screening. They talk about colon screening. They talk about cervical cancer screening. And if you've been a smoker, they'll talk about lung cancer screening. But when does your primary care doc say to you at age 45 to 50? And I'd argue 45. You know, Joe or Jane, we're going to take this big burden of heart disease on, and we're going to focus on you, and we're going to measure in you if we can detect any early signs of atherosclerosis. And I actually want to tell you, atherosclerosis, the first word is atheroma. And that's not a word you hear a lot, but it's one you hear in medicine. Atheroma, sometimes defined as like an oatmeal-like gruel, G-R-U-E-L, that is inside the artery obstructing it. But the original definition of atheroma was a tumor, because you basically have a tumor in your arteries if you have atherosclerosis, and it's spreading and spreading, and it metastasizes from one blood vessel to another, from one organ to another. But we don't talk about it that way. But I want you to think about heart disease as something we need to approach like cancer. We got to get that excited. You need to be screened for it. You need to be staged. You have stage 0, stage 1, stage 2, stage 3 heart disease / cancer. And I'll show you how we do that now. It's advanced, but it's widely available. And we need to use chemotherapy, and broccoli is chemotherapy, and a treadmill is chemotherapy, but so are certain supplements like coenzyme Q10, and aged garlic is chemotherapy, and certainly some of the prescription drugs are chemotherapy. The only difference is, and I'll get moving from this slide in a second, is that there are some cancers that you can cut them out for isolated breast cancer, prostate cancer, for example, melanoma, or maybe you treat with chemotherapy like non-Hodgkin's lymphoma, and you're cured for life, and you ring the bell, and then you're 5, 10, 20, 25 years out, and you're in good shape. That's not the case with atherosclerosis. You may have had a stent, a bypass, a heart attack. It's going to be your whole life that this tumor is spreading and growing. And your whole life, you have to pay attention to your exquisite lifestyle, your lab values, your advanced imaging, and your chemotherapy that you use, whether it's broccoli sprouts or whether it's a low-dose statin. So I'll talk about. So let's focus on heart disease. And I'm not here particularly to sell you books that I wrote, but this is the second book I wrote. It's been updated. Dead Execs Don't Get Bonuses. You can buy it online at the sellers. And its whole focus was to give people a guide, basically like a cancer guide. Like I'm thinking of Dr. Christy Funk, a very well-known plant-based breast surgeon in Los Angeles. She's got her breast guide. This is a heart guide, what to ask for, how to be screened, and how to start preventing this with an analogy that it's like a cancer. And that's step one, is to focus on heart disease. Go to your primary care doc and say, I want to wage a war on my body to find out where I'm at. And if I have it, I want to wage a war to halt and prevent it and shrink it. And I want to start treating my body like the concern you have about cancer. I want my concern. The second thing you need to know is that heart disease starts young. And we need to be teaching people to start young. You know, if we saw an 18-year-old smoking, and if you had a child that was 18-year-old smoking, you might talk to them about their risk of lung cancer. And yes, that might take a long time to develop. If you saw a young person eating terribly and obese, you might talk to them about their risk of colon cancer, because colon cancer is growing in risk in the young people. But heart disease is even worse than that. This is one very famous series of studies of Korean casualties, Americans who were 20, 21, 22, where the amount of atherosclerosis on their autopsy at age 20, 21, 22, 23 was extremely high. And it was also true in Vietnam and the Iraq incursions. Sometimes these were small plaques, sometimes these were severe plaques in young people. So if you have children, it doesn't matter if they're 7, 17, or 27, it's the time to have a heart-to-heart with them, literally, about their diet, their weight, their blood pressure, their sleep patterns, and their fitness program, because they are developing atherosclerosis more likely than not. When you look to the left, and a little dated, but nothing really has changed, the causes of death in the United States, even 24 years ago, were number 1, heart disease, and number 2, cancer. But this insightful series of studies that were published showed that we can go beyond just saying that. And we should say right now, the number 1 cause of heart disease and the number 1 cause of death in the United States is actually lifestyle factors, followed closely by genetic factors. But we can't control, we can measure, but we can't control our lifestyle, our genetic factors, but we can control. So smoking, poor diet, and physical inactivity, sitting, either by a job that requires to sit or just a lack of attention to fitness, are the top 3, 85% causes of death in the United States. And we know if we can teach young people, middle-aged people, and the elderly not to smoke, to eat whole food, largely or exclusively plant diets, cooked at home, watching salt intake, and get people moving, standing, treadmills, walks, and more intense fitness, we can make a major inroad on preventing the disease at its start. Perhaps you know this slide. Dr. Dean Ornish is famous for this slide. Others use it. But this is the American medical system. The sink is on, the sink is overflowing and spilling on the floor. And us doctors and nurses are mopping up the heart attack, the stroke. We are using stents, we're using bypass, we're using defibrillators. But what's going on with the sink? Nobody's paying attention to those 85% of factors that are lifestyle controllable: the smoking, the weight, the sleep, the nutrition, the vitamin levels. And we can measure genetics. Would you like to know if your genetic risk was high, so you had to really focus even more on prevention? Would you like to know if your genetic risk is lower? These are widely available nowadays. Perhaps in the Q&A, you can ask me about that. So we do know that roughly 85% of atherosclerotic heart disease may be preventable if we start early enough and we get excited enough and talk about this as a war on heart disease, equivalent to the war on cancer. We also know that while you're working on preventing heart disease, you'll reduce your risk of type 2 diabetes, cancer, dementia, obesity, arthritis and other conditions. Things go together. That's the functional medicine network that we proudly attack. Do we actually know that we can prevent so many heart attacks? These are two studies now about a decade old from Europe, but they assessed in nearly 40,000 men and women, those people that avoided smoking, exercised 30 to 40 minutes a day, ate a higher than average number of servings of fruits and vegetables a day, slept more than 7 hours, not less than 5 hours. And actually, one of the benefits in this study, quite controversial, was people who did enjoy a few glasses of wine a week. And when they found people that did all 5 bullet points and they followed them over time, they had 85% lower risk of heart attacks than people that ignored these simple lifestyle factors. Now, I'm not encouraging you to drink a glass of wine. That's totally your deal. But I am encouraging you not to smoke, to walk every day, to eat a large number of fruit and vegetable servings, and to focus on good sleep. I was in bed 9 hours last night, probably slept about 8, and that's pretty typical. So how are we going to start kicking the ass of heart disease? And it has to start with a philosophy I call test, not guess. But it's not new, it's old. And 400 years ago, this English physician, and I apologize, the word person should be about half an inch higher on the slide. Somehow in the translation, it got moved down. But this famous English physician, Thomas Sydenham, said, a man is as old as his arteries. And let's just substitute the word a person is as old as his or her arteries or their arteries. But do you know, you the audience who have partners and spouses and brothers and sisters and parents and children, do all of you know how old your arteries are? Because if you don't, you're an amateur. And if you actually know how old your arteries are, I'm proud of you, but you're a professional in this game of kicking heart disease in the ass. One of the problems is pointed out in this meme slide. If coronary artery disease was attacking your face rather than your heart arteries, you'd do something about it, and you would. But we're talking about a disease that is silent. It's easy to detect. I do it every day in people of every age, but it is silent, and we ignore it, and we don't get excited about it, and we don't think about it like we think about cancer risk. So there has been an effort for 25 years to detect heart disease early, because the awful truth is doctors are not wonderful when they're sitting with a patient at being precise at assessing if a person has heart disease and is going to perhaps die early, or doesn't have heart disease to the point that it's going to cause them to die early. Whoever would have predicted that Winston Churchill and his size and smoking capacity and diet would live to 91, when a very famous runner, some of you are old enough to remember Jim Fixx in the Book of Running in the 1970s, died of a massive heart attack at age 53, despite being the guy who pretty much put marathon running on the map in the United States. Never would have predicted it. Now, it's rumored that Jim Fixx had an extremely high cholesterol, probably genetic, and a very poor diet. And maybe somebody could have got to him. And I hear that people did talk to him about it, but he would say, I can out-exercise my diet, don't worry, but didn't work out for him. And there are people watching this presentation right now that have the problem that the black arrow on this heart catheterization angiogram picture is pointing to, which is we call it a lesion or a narrowing or a stenosis of a heart artery. In this case, the widowmaker proximal left anterior descending artery. And believe it or not, your artery can be narrowed so tight and you don't have symptoms, or you have subtle symptoms. Perhaps you're just a little winded, a little tired, a little burning in the chest you attribute to heartburn or fatigue. But this can kill a person, within 6 minutes of a cardiac arrest. And it does that over 600,000 times a year in the United States, according to the statistics I presented. Do you know if you have this problem? Wouldn't you want to know, even though it'd be bad news? wouldn't you want to roll the dice in your favor and attack this problem with chemotherapy, surgery, and lifestyle bombs all over the place? So there are some interesting clues beyond just having a heart catheterization. There's some data that people that go bald on the top of their head early in life may have some premature aging of their arteries. It's similarly around the temples. And there's actually some data, scientific studies, that having salt and pepper, gray hair early in life is a sign of oxidative stress and imbalance, and could be a clue that the heart arteries are also under stress. Certainly, if you have yellow deposits around your eyelids, you can have a genetic cholesterol disorder and get your blood checked. And then there's the strange one called the earlobe crease, but that comes up over and over. I have to use my digital friend, Steven Spielberg. I've never met him. But if you look at his earlobe and that deep groove, he didn't have that when he was a bar mitzvah boy of 13, I can guarantee you. It accumulates over time. He doesn't wear heavy earrings that dragged his ear down. But in the 1970s, a doctor in New York published a paper that when I see a earlobe crease, I tend to pick up heart disease in my patients. And when I see smooth earlobes that don't have a crease, I tend to see people that don't have heart disease. And it was celebrated as an interesting advance. It was forgotten, but in the past 10 or 15 years, there's a number of studies that have confirmed that if you have a deep earlobe crease, get your heart checked. It's not going to prove to be bad news for everybody. It's about 70% accurate. And there are actually people that schedule an appointment to see me in my clinic solely because they looked in the mirror, and it's usually both ears, and they won't go away over time as far as we know, but they weren't there if you look at a picture 20 years before. Another very important clue, hopefully everybody knows, but boy, everybody in my clinic gets asked about, is erectile dysfunction, the canary in the coal mine. The fact that a man having difficulties in sexual performance, not really libido, but sustaining erections, may have clogged arteries or atherosclerosis below the belly button, but may also have clogged arteries and atherosclerosis above the belly button in the heart. And all men with erectile dysfunction should get a very aggressive check of their heart arteries, as well as being considered for testosterone replacement therapy, if appropriate, or lifestyle measures and beets and greens, and if needed, the erectile dysfunction drugs, Cialis and Viagra, which increasingly are viewed as very safe. And recently, both Cialis and Viagra have been shown to possibly lower the risk of dementia, if you didn't read that recently, and maybe even prolong life. So I recently wrote a blog article about these two drugs, anti-aging drugs, and it may prove to be the case. And I wouldn't be shocked in 10 years if women aren't taking low doses of these drugs for longevity. But let's wait and see. All right. So what are the tools of the heart attack, aggressive kick heart disease in the rear prevention specialist? And in the upper left, you see a CT scanner. We'll talk at length about that. In the upper right, you see a ultrasound probe on the neck that's over the carotid arteries. And below, the lower right, is a digital image of a special carotid ultrasound. A lot of you have heard of Lifeline screening at the church, at the school. There's nothing wrong with it. It's cash pay, but it is not the most accurate kind of carotid ultrasound. The most accurate kind is called a CIMT. It's hard to find a place that does it. My clinic does, but we may be the only place in the state of Michigan that offers it. Many universities don't offer it. It's worth trying to find a place to do it. And in the lower left is a comment about traditional blood work. Traditional blood work may miss half the people at risk for a heart attack. And we're going to talk a bit about advanced blood work, often insurance-covered blood work. And increasingly, you can just buy your own lab package. I'll tell you where in a minute. So I never met Dr. Ernest Schaefer, a European vascular specialist and academic doctor, but he said very poignantly about 40 years ago, the best test to predict the risk of atherosclerosis is the demonstration of atherosclerosis. Let's look for it. You wouldn't have a doctor tell you, I think you might have lung cancer, and not order a chest X-ray or a chest CT. You would look for it. And we need to stop talking about atherosclerosis. Remember, atheroma, the first part of the word, is an old word for tumor. We need to look for these tumors that are growing in your arteries. Could be the carotids, could be the heart, could be in your abdomen by your aorta. You've heard the term aortic aneurysm of the abdomen, and could be in your leg arteries with a simple ultrasound. That's more common in Europe, that they'll scan the leg arteries for atherosclerosis. Simple test. All right, let's move forward. Dr. Schneider, thank you. And you can see in the circle, in this rather busy slide of screening for atherosclerosis, there's a variety of choices, but there's two ways to directly look at the arteries. One is the carotid IMT, CIMT ultrasound of the neck, simple test if you can find it. And the other one is the CT scan that we'll talk about, called the coronary artery calcium CT scan. It is the heart's mammogram, the heart's colonoscopy. If you're in this audience and you've not had a coronary artery calcium score, either one, you've already had a heart attack, a stent, or a bypass, so you know you have heart disease and you don't need that test. Or number two, you're an amateur. If you've not had a coronary artery calcium score, if you don't know if that number is 0 or 4 or 74 or 748 or 1674 or any number like that, you are an amateur. You are playing with a loaded gun. You don't know where that bullet is, in a roulette analogy, and you need to move forward and fill that gap soon, right away. Get that test scheduled. So if you look here, very instructive slides. I wish we could teach more cardiologists this. This is looking at the ability of a heart CT scan, cardiac CT, versus a stress test to pick up early asymptomatic atherosclerosis. Could be in heart arteries, and that's what this is about. Could be in other arteries. So if you look early, there's a column that says early, where there's no obstruction, no symptoms. The stress test will clearly be normal, and the CT will probably be normal too. But I want you to look in the column that says moderate. This is the key. The disease has started. You don't know it because there's no symptoms unless you have an earlobe crease and your hair is gray and you're bald on top, but you don't have any cardiac symptoms. If you do a stress test, you'll pass it every time. Forget about that executive physical stress test. It is worthless. It is. Tells you your fitness. That's a value, but you can judge your fitness if you can run up and down stairs rapidly and easily. But look what happens. The stress test will be normal. You'll get no actual important information, but the cardiac CT scan will pick up those white spots. What are those white spots? Calcium. And in almost all plaques, well over 95%, there's calcium in the plaque. And you can identify this on a simple CT scan, a safe CT scan, a widely available and widely affordable CT scan. So wouldn't you want to know if you're in the moderate column so you can start aggressively attacking your risk in the future? I tell my patients all the time, we're working on your risk in 20-year increments. I'm not worried about you right now. I'm worried about you in 20 years. And we're going to start as early as possible. And right now, the moderate column is the most available column to identify. Then as the disease gets more advanced, you see the column, 50% blocked arteries, you still won't have any symptoms. Even during pickleball, you still will pass a stress test, but your cardiac CT scan will be very abnormal. Only when the disease is very late, when arteries are 70, 80, 90% blocked, big arteries, will you be short of breath, having chest pressure, having burning in the chest, having fatigue, and then your stress test will be abnormal. And again, your cardiac CT will be abnormal, but do you want this disease picked up late or at a moderate stage? And it is even possible to pick it up at the early stages now. It's available. I'll tell you about that in a couple of minutes. But it's a little bit more expensive and a little bit more exclusive to pick up the early. So way back in 2007, a society of cardiac specialists was formed called the SHAPE Society. It stands for Society of Heart Attack Prevention and Eradication. And they recommended take a apparently healthy population, all you people watching this right now, and all your partners and spouses and brothers and sisters and parents and children, men over 45, women over 55. And I might disagree with the women part, maybe 50. And if you have serious concerns like smoking or a family history, maybe earlier, and do a test that says it in bright blue, aqua blue, for atherosclerosis. And they're talking about get a prescription to get a coronary calcium CT scan, find a center that does the right kind of carotid ultrasound, a CIMT, and find out by those two tests if you're over to the left, yellow, low risk, or way over to the right, very high risk, even though you have no symptoms, and treat aggressively. And this is basically staging. You know, if you were told by a oncologist or a surgeon, well, you got breast cancer, and you were to ask, well, how bad is it? How extensive is it? What stage is it? And they said, we don't believe in that. You would go shop for another specialist. Cardiologists don't talk about staging heart disease. And we can now, and I'll show you that. But this was an early attempt to stage it from a low risk to medium to high risk. And we treat it differently. We're going to treat the very high risk person very different than the low risk person. I'm a yellow box person, and I don't take cholesterol lowering medication because I'm very low risk based on my heart CT scans and my carotid ultrasounds. In fact, I just had a carotid CIMT done yesterday in my office. I'm waiting on the results. I do it about every 2 years, but I'm a low risk guy, so I don't need an aspirin a day. But many of my patients seem just like me, healthy, fitness, diet, sleep, stress management, and they turn out to live in the red box because we do the testing. So everybody needs to know the results of this test, the coronary artery calcium score, CACS. Some people call it the CACS test. I don't. About 80% of hospitals in the United States offer this test, and many in Canada. In most states, you have to pay cash. I'm aware in Texas and maybe Hawaii, your insurance will cover one routinely around age 50. You need a prescription from a healthcare provider. That's a blockade, because some of them won't do it. I hear this story over and over. My family doctor would not give me a script. They thought I was too low risk, and then the test comes back abnormal. But if you look to the left, panel A, the yellow arrow is pointing at heart arteries. No white spots, no calcification. Good news. Panel B, yellow arrow, white spots, calcification. That's that moderate disease we're picking up. No symptoms, normal stress test. Never find it on a physical exam with a stethoscope. And boy, oh boy, pickleball player number C. I have pickleball players just like number C. Their arteries are basically stone, rock, calcified, but they feel okay. Then sometimes they even pass stress tests. They don't all need bypass or stents, but boy, they are, if you were staging their cancer, heart burden, very advanced. They need therapy big time, and we'll help them with that. So this test takes about 1 minute. It should cost about $100. There's no IV, there's no injection. You can't be allergic, and you really can't be claustrophobic because the CT scanner is nowhere near your face and it's not tight near your body. And the radiation exposure is very, very low. Heart disease takes more deaths than any other cause in the United States. We should take a little risk and a little expense and get this done. And this is what you want to see. That in this case, 4 major arteries, and then point number 5 is the total. Everything is 0. This was my report about 3 years ago. I do this about every 5 to 7 years, so 0 is great. I've done this since age 40. I'm turning 65, so I'm glad to keep this a 0. And there's so many research studies. There's about 6,000 research studies on coronary calcium scoring. And the power of 0 for extremely low risk of stroke, heart attack, congestive heart failure. And it also seems to indicate good health body-wide. Brain disease, kidney disease, lung disease, all are lower in people with a coronary calcium score of 0. You probably good genetics, and good lifestyle for a long time. This is AHA, if you look in the upper right, is the American Heart Association. And although that Shape Society was way back about 18 years ago, if you go way down where the red circle is, it's really small print. I'll read it for you. But it says, if you have a CAC, a coronary artery calcium score of 0, you may not need statins. So your doctor says to you, your cholesterol is 230, Joe and Jane. Here's your prescription for rosuvastatin. And you say, I feel wonderful. I heard a lecture by a Dr. Kahn, and even the American Heart Association now agrees. Give me a script for a coronary artery calcium score. Let me find out if I'm a 0 or a 300. If I'm a 0, I'm not sure I want to take that prescription drug. I'll eat more ground flaxseed and broccoli sprouts. And if I'm a 300, okay, you win. I get that maybe I should focus on chemotherapy for my heart disease. All right, here's that carotid study, CIMT. The machine to the left, the patient very nicely volunteering her picture with a probe on the neck. Very simple test, no radiation. But it's not just seeing the plaque, it's also measuring the T, the thickness of the artery. It takes special digital and AI-enhanced software to do all that, but it's been around for a long time. About 2,000 research studies say this is a good test. And this is an example of a report. On the top of the picture, there's a right carotid artery with one small plaque, less than 20% narrowing. On the top left, there's one larger plaque, 3.623 millimeters. Heterogeneous means it's a mixture of hard and soft plaque, less than 20% narrowing. And this person was 56 years old, and their arteries, the thickness was more like a 60-year-old man. So we got some work to do here. Not tragic news, but you can repeat this scan in a year and see these numbers improve, and sometimes see the plaque disappear. This is what you'd like to have, a right carotid and a left carotid that show no plaque. And if you look below, a 60-year-old driver's license age, but the arteries look like a 51-year-old. That was mine about 5 years ago, and I'll see what this newest one comes out during the week when I get the results back. Hoping to keep it clean and young, but we all are at risk. Cardiologists are not immune from heart disease. Sadly, many cardiologists, we just had one in Detroit 6 weeks ago, dropped dead. Suddenly, you're gonna presumably of a sudden heart attack, and we're at risk too. So it feels so good to know the score. The sweaty guy on the left knows his calcium score is 0, and I'd certainly introduce women in this picture too. But the guy in the red has no idea what his calcium score is. That's basically leading life without your without your seatbelt on. That is a risky approach. And again, I'm urging you all to be more aggressive. So, action step. Colonoscopy, or maybe you do the stool test called Cologuard, mammogram, or maybe you do the test, the thermogram, and check the box. Check the box this week. Go to your primary care doc and say, I've never had a bypass, I've never had a stent, never had a heart attack, but I've never had a calcium score, and I'm living life blind, and I'm going to step up my war on heart disease and see where I'm at. All right. Paradigm shift, change from one way of thinking to another. Humans resist that, but attacking heart disease like cancer, fighting heart disease like cancer is now the new paradigm. So I want to talk to you about a new paradigm out there. This is a physician. You won't really know much about him unless you're a cardiologist. But at the Cleveland Clinic, Dr. Mason Sones, a year before I was born, found out that with a little catheter put in that case from the arm, later on from the leg, and later on from the wrist, he could make pictures of heart arteries. And those heart arteries are called coronary arteries, and the test was called a coronary angiogram, or a cardiac catheterization. Some of you in the audience have probably had a cardiac catheterization, and you need to thank the Cleveland Clinic legend, now deceased, Mason Sones, for that. But this is the problem. The red arrow is pointing to an area that is narrowed compared to the area after it and a little bit compared to the area before it. This is a heart artery. It's called the right coronary artery. Since the introduction of cardiac catheterization, this has largely been measured by visual estimates. That looks about 50% blocked. But even if you look below, that means 40 to 70% blocked. And research studies show, this is a secret of cardiology, that we're not very good at agreeing on how much blockage there is. When we get a group of cardiologists and look at this film, and we have them quietly write down on a paper what they see, the numbers are all over the map. Yet, we're using this invasive test to pick people for stents and bypass. And one cardiologist writes down 30%, and one cardiologist writes down 80%. And one patient gets a stent, one patient goes home with an aspirin. So this is not just my opinion, but these are two papers in the 1970s that talk about the variability in coronary angiography. And they basically did take a series of catheterization films and a series of experienced cardiologists. They had them write down what they saw and they published the data. And it's a very concerning high degree of variability, 30 to 90% for any single lesion. So about 2010 came a new technique that did not require putting a catheter in the body. So it goes back to our CT scanner, one of the tools of the preventive cancer treating, heart disease treating cardiologist, coronary CT angiography. And if we do a CT of the heart, but we inject iodine dye through an IV, we can now see the arteries without putting a catheter in the body. So this is a test that is now about 14 years old. And you can see an artery to the left in green with no coronary artery disease. And this is typically how these are reported at the hospital. Less than 25% narrowing, the yellow one, 25 to 49%, the orange one, 50 to 69%, the lighter red one, and then the darker red one over 70. But these are still visual estimates. These are best attempt. And when you get 5 cardiologists looking at the same CT angiograms, you're going to get different numbers. You can't help it. So that was 14 years ago. But over the years, the word everybody hears all the time now, AI, artificial intelligence, became applied to these CT angiograms. Interestingly, it's not yet really routinely applied to heart catheterization, the invasive test, but it's routinely available. I've ordered hundreds and hundreds and hundreds of artificial intelligence coronary CT angiograms on people all over the United States because I'm licensed from coast to coast. And I have patients from California, New York, and Florida to Minnesota. And we can measure, as this picture shows, using a computer that draws these yellow lines and purple lines. And the computer will measure, independent of the eyeball, how much plaque there is. And also can tell us what kind of plaque. You won't be quizzed on this, but there are plaques at the top, a necrotic core plaque with a red asterisk that's very high risk for heart attack. I had a patient yesterday morning in the clinic, and I showed him his data on his AI coronary CT angiogram with a necrotic core high-risk plaque. Or you can go way down to the bottom in green, where you have a plaque that's completely heavy calcium. And it's abnormal, it's atheroma, it's a tumor, but it's a much lower risk. So this is a revolution. This is a paradigm shift. This is the best test on the planet that everybody can have done if they're appropriately screened for and can afford it, because insurance doesn't always pay for it. And you can see the arrow just popped up. The top one is the high risk, and the calcified dense area is low risk. So not all plaques are the same. We can't tell this in the heart catheterization lab. Isn't that amazing? It's this artificial intelligence CT scan that tells us, if you look to the left, that red plaque is that high risk, low density necrotic core, maybe a heart attack coming plaque, like I shared with my patient yesterday. And way to the right, color-coded in blue, is calcified plaque, hard plaque, old plaque, not normal, but probably not going to cause a heart attack. And the ones in the middle are a mixture of yellow being non-calcified fatty plaque with some calcium mixed in. We can do this routinely now in the heart arteries. Does it matter? Well, I want you to see something to the left that we now talk about in special clinics like mine, staging heart disease. Uh-oh, that's cancer talk. Yes, we're staging heart disease. And my notes in my clinic will always indicate if a patient's had an artificial intelligence coronary CT angiogram. Are they stage 0? Very few people, but some are. Stage 1, stage 2, or stage 3. And published last year was a study proving it makes a difference, because this is a new paradigm, so you got to prove it. And the people that are stage 0 over 10 years had a very, very low risk of events compared to the blue line that's going down and down and down over 10 years that had almost a 50% risk of having an event in the next 10 years. So, of course, then we need to intervene. We're staging, and we're not treating people the same. The people with the line that's flat on the top are getting treated less aggressively. And the people with the blue line going down and down and down, we're attacking them with a war, everything we can do. So there's even now therapy. This is a paradigm shift. This is Dr. Andrew Freeman. It's kind of funny. I was just reading in a magazine you may get called Health Science, an interview with Dr. Andrew Freeman, cardiologist in Denver. But he has proposed with a group of colleagues that if you have stage 0, we might want to recheck you in about 4 years. That's the top yellow or beige line. And you have no narrowing, and we're probably going to mainly emphasize lifestyle. Stage 1, you've got disease, and you might get away with some low-dose medications and lifestyle and being rechecked in 3 years. Stage 2, we're going to throw more at you, including aspirin and blood thinners, and we're going to recheck you in about 2 years. And if you're stage 3, as many of my patients are, we're throwing the kitchen sink at you. This is war on cancer, but it's heart disease. And we're going to use every pharmacology, lifestyle tool in my office, supplement tools, exercise tools, stress management tools. So this is a whole new game, a whole new paradigm. You've never seen this before. There's lots of research using these artificial intelligence coronary CT angiograms. They've studied statins, and you may not be a believer in statins, but I'm telling you the data. Statins cause regression. That means they make the plaque smaller. Estrogen's been studied, it's neutral. Xarelto, a blood thinner, works better than warfarin. It slows progression if you need it. Fish oil slows progression. Hopefully, also true of the vegan versions, algae oil, but fish oil is what's been studied. Interesting, testosterone's been studied as a gel in one study, and it caused progression. It was judged to be harmful, and that needs to be reproduced. And then the last two, atorvastatin is another statin. It causes regression, shrinking of the soft plaque, that yellow plaque. And finally, an old drug is now being used widely in heart patients. Colchicine is a medication used for gout, and in a recent study, it also can cause soft plaque to shrink, and we're using it more and more in heart patients. Part of our war on heart disease. It's diet, it's exercise, it's sleep, it's fitness, it's supplements. It can be cholesterol-lowering drugs, blood pressure-lowering drugs, blood thinning drugs, but now it extends to an old gout drug that's being reused for heart disease. This is a fascinating study published in 2016. A lot of my peers in this country don't use supplements. I do. And I want you to ignore a recent video that was on nutritionfacts.org, sorry to say, that said that aged garlic tablets weren't of use and you might as well just use garlic powder. I disagree with that video completely. This is the published science, and it's not the only published science, but if you look in the middle where it says low attenuation plaque, that's a dangerous, dangerous plaque in heart arteries. After a year of taking tablets that are aged odorless garlic, the low attenuation plaque starts to melt away. And if you're in the yellow, the placebo, it doesn't go away. The pink is the people that were treated. This is called a double-blind, randomized, controlled study. This is real science, and I don't care if my patients use garlic powder, but I definitely want them, if they have soft plaque, to add in aged odorless garlic tablets, usually about 2,000 milligrams a day. And they may do that with all the other things we've talked about. So supplements do have a role, scientifically shown. Now, the interesting thing with this new paradigm, artificial intelligence, coronary CT angiogram, you have to have an IV, you get iodine dye, so you can't be allergic to iodine dye, and you have to have good kidneys, is that we can do this a year or two later. And this is a woman that refused to go on therapy. And when we looked at her arteries that were followed up a few years after the baseline, her plaque got worse because there was no therapy. And that therapy includes diet and fitness and weight control and blood pressure control and blood sugar control, blood cholesterol control, and inflammation control. So we can document. That's a new paradigm because now we can measure accurately using AI CT. Here's a 56-year-old man that was put on a high-dose statin and hopefully diet and exercise. 3 years later, his plaque basically didn't change, so we stabilized things. And this is an example of somebody taking really intense cholesterol-lowering therapy, an injectable version called Repatha and Praluent. And over the course of a follow-up study, just 1.5 years after the first one, there was a significant shrinking. And what you do is you shrink the soft plaque, the non-calcified plaque. You don't shrink the calcified plaque. We don't know how to get the calcium out of the arteries. We don't see calcium scores going down. We don't even know if we want calcium scores to go down, but we want soft plaque, the yellow plaque, the abnormal juvenile plaque. So just read with me the bullet points. Coronary CT angiography, artificial intelligence can be used as a non-invasive imaging modality. I wouldn't necessarily say low cost. It's about a $1,500 study, but I would say low risk unless you're iodine allergic or have poor kidneys. The AI CT study may allow more wide use to assess drug efficacy on atherosclerosis progression in primary and secondary prevention populations. That's you, everybody. And finally, precision tracking will allow individual assessments. That's what's really neat now, is seeing people back after a year or two of intense imaging. And if you want to know the answer to a question, nobody's done a study using this technology with the Dr. Ornish diet, the Dr. Furman diet, the Dr. Esselstyn diet. Nobody's done that study yet. It costs a lot of money to do formal clinical trials. So most of the trials so far have been done with drugs. I showed you the one done with aged garlic. There's more and more being done with a new study being launched called the Paradigm Study that will be throwing the kitchen sink at high-risk heart patients, and then they'll get a follow-up CT angiogram. Now, I've ordered hundreds and hundreds of these studies, and I started doing that 3.5 years ago. So I've had a number of people get their second study. They want to do it. They have to pay for it. Usually it's not insurance covered, as I said, about $1,500. Not everybody wants to do it. I rarely order this on people with a calcium score of 0, but when you do see quite a bit of soft plaque. So even a calcium score of 0 misses. And I am a person with a calcium score of 0, but I had one of these AI studies and I had a pinpoint little spot of soft plaque. No big deal, but it was there. So now we could answer interesting studies. Put people with heart disease on the Ornish diet, put people with heart disease on a ketogenic or carnivore diet, and check them again in a year. I don't know who's going to fund that, but that would be a fun study. How about doing the Esselstyn diet with extra virgin olive oil and without extra virgin olive oil? Fund that study. That would be a fun one. Chelation therapy, people ask about intravenous chemicals. Probably not going to be done because a study published in the last 2 to 3 weeks showed it once again failed to show benefit. How about dairy? Good or bad on heart arteries? That'd be a fun one. How about fish? Good or bad on heart arteries? How about the very popular Prolon fasting mimicking diet I use in my clinic? We don't know what that does to heart arteries. We know it does to we know what it does to waistline and blood tests, and soon to be published a concept called autophagy. But that would be a fun one too. Maybe we are shrinking soft plaque. Maybe we're not. We now can study it. Okay, let's move along here. Our war on heart disease, kicking it in the butt like cancer. And I already mentioned that advanced labs are part of the war on heart disease, part of the aggressive paradigm shift. Because in many studies, this is just one, people who are hospitalized with, for example, heart attacks, very often have relatively unremarkable LDL cholesterols. And even some, if you look, have LDL cholesterols of 50, because LDL cholesterol is one of easily measured 15 to 20 different lab tests for a heart patient. So you might have a normal LDL cholesterol and have 14 other lab tests that are abnormal. This is a picture from a pharmaceutical journal a number of years ago. That's supposed to be an artery with a plaque. It looks like yellow butter because this person probably ate too much butter. But those daggers are things that can be measured in the blood that can cause plaque. And I'll tell you, since this was published 12 years ago, there's about 8 more new daggers that weren't on here, like TMAO and lipoprotein a. But it's just to point out, you might want to measure all these blood levels, all these daggers, your omega-3 level, your C-reactive protein level, your insulin level, your nitric oxide level measured as something called ADMA and others. And we know for sure that cholesterol, LDL cholesterol, is not the only factor, that inflammation is a big factor. There are, on this slide, 1, 2, 3, 4, 5, 6, 7 tests for inflammation, of which I do all these in my clinic. They're urine or blood, they're available, and they help sort out, they stage a person. A person with an abnormal calcium score, and all these 7 tests are normal, is much lower risk than a person who has an elevated calcium score, and all these 7 tests are abnormal, and they're available. I mentioned colchicine, a new kid on the block in heart disease. This is a famous study published about 4 years ago. This was a big study, 5,000 patients with what are called chronic coronary disease that either got colchicine or they got a placebo, men and women, double-blind, randomized. And if you look to the right in the middle, the placebo group had a 9.6% rate of events like heart attacks or death, and the colchicine group, it dropped by about a third. So you'd rather be on the colchicine than be on the placebo. And colchicine is now FDA approved for heart patients. It's a new drug called Lodoco, L-O-D-O-C-O, but it's also available as plain old colchicine we used to use for gout. So the action step is go back, rewatch this, write down those tests, and get tested for inflammation. 1 test is better than 0. 7 tests is better than 1. Okay? Number 7, as we stage a war on heart disease, is lipoprotein a. And unfortunately, my PowerPoint doesn't let me put a lowercase a on the title slide. But if you look at the book I wrote on this topic a couple of years ago, with delicious recipes included, you can see that it's lipoprotein a. That's actually how you pronounce it, lipoprotein a, or LP a, the heart's quiet killer. And this is a cholesterol molecule. As I explain to my patients, 100% of people make regular cholesterol, LDL cholesterol, but 20 to 25% get a gift from their parents, and they make 2 cholesterols. They make regular cholesterol, LDL cholesterol, and they have now the capacity in the liver to also make lipoprotein A cholesterol. And we know that this is a particularly nasty cholesterol. And a recent study said it was 6 times more dangerous than regular cholesterol because it can cause plaque in arteries, it can cause clotting in arteries, and it can cause inflammation in arteries. It actually looks a lot like an LDL cholesterol molecule, but it has a bridge and it has this special tail on it called Kringles, which is named after a Danish pastry, another thing you probably don't want. You don't want lipoprotein a, and you probably don't want the Danish pastry. I've never had one. But my clinic is full of people that are suffering from silent but important heart disease, and we identify this as elevated in the blood. It's a very simple blood test. Everybody should have this blood test. And if you use a cutoff of what a normal and abnormal level is, it's estimated that about 1.5 billion people in the world are walking around with high levels of lipoprotein(a). At this point, there is no drug approved by our FDA for lipoprotein(a). Lipitor, nope. Crestor, nope. Pravachol, nope. Zetia, nope. None of them are. But the pharmaceutical industry is working on about 5 different approaches, and within the next few years, we will have drugs. They'll be expensive. They'll start out with injectable drugs. Later on, there'll be oral drugs, and we will have better solutions. This is a genetic problem. It doesn't respond well to diet and exercise. But it's very important. It's estimated that 1 out of 14 heart attacks is due to lipoprotein(a) cholesterol, and 1 out of 7 cases of clogged aortic valves leading to aortic valve surgery and aortic valve replacement is due to lipoprotein(a) cholesterol. 1 out of every 4 or 5, it depends what population selected. So if we have a large number of people watching this presentation live, and more people will watch it recorded, and I can tell you 1 out of every 4 has lipoprotein(a), and you got to go to your primary care doctor or order the labs on your own and get it checked once. That's not just my recommendation. That's a recommendation of the European Society of Cardiology. And just recently in the United States, it's a recommendation of something called the NLA, the National Lipid Association, cholesterol experts. Everybody should know as early in life as possible, because you're going to have this in your blood if you inherited it from about age 1 forward. It's going to be in your bloodstream. You want to know if it's elevated. So maybe by age 20, everybody should know ideally. And the people with high levels might want to eat even healthier than average, might want to work out more than average, might want to know their blood pressure, their blood sugar more than average. And when we get treatment, they may want to consider that. So the action step is give a tube of blood, get your lipoprotein(a) checked, okay? All right. Let's talk about the optimism of the war on heart disease, that heart disease is reversible. We may not be able to get the calcification out yet. And I'll just tell you, a recent study with vitamin K2 at very high doses failed to show that it takes the calcification out of the arteries. It also didn't take the soft plaque out of the arteries. So vitamin K2 has gone down on my list of agents to use in heart patients. There may be a reason to use a high dose of a special vitamin K2 called MK4 for bone health, but not for heart health. But I want to take you through a little path of history. I already mentioned Mason Sones in 1958. Now we got to go back even a little earlier. And the gentleman to the left holding, it looks like a notepad, wearing glasses, is Dr. Ansel Keys. He had 2 PhDs. He was a professor at University of Minnesota. And he was interested in the question in the 1940s and 50s, why are there so many heart attacks in Minneapolis that we didn't see 10 and 20 years ago? He suspected it was changes in diet in the American culture. And he went to his friends across the United States, Japan, Italy, Croatia, and other places, and said, let's do a study and look at, is there a factor in the diet? So this is a little town in Italy where they were meeting to plan a serious research study that started in 1958. And they ended up following patients for 25 years, and they knew what they ate. They knew their blood levels. They knew what was in the food they ate. They knew about smoking, blood pressure. This is all before computers. A very difficult study, very funded on a shoestring, but meaningful. It's called the 7-country study. And what they showed in this case is the higher the saturated fat intake in the diet, the higher the death rate of heart disease over 25 years. So if you look in the upper right, E, that's a country with a very high saturated fat intake and a very high heart disease risk. That happened to be Finland. And you look way down to the lower left, T, that's Japan, very low saturated fat intake in the 1960s and 70s. Things change when Kentucky Fried Chicken shows up. and a very low heart disease risk. And when they looked at cholesterol levels and mortality over 25 years, countries with a very high cholesterol in the upper right, Northern Europe would be Finland, had very high cholesterol levels and very high heart disease risk. And when you look way down to the left, Serbia and Japan and others, average cholesterol in the blood of these people, 126 total cholesterol. That's not on drugs. That's because their diet was so different than Finland, for example. It was so low in saturated fat. And they proved it wasn't really dietary cholesterol, it was dietary saturated fat. The stuff you find in whole milk, cheese, egg yolk, red meat, white meat, fish meat, coconut oil, palm oil, although none of these cultures used a lot of coconut oil or palm oil. That's why you hear the guidelines you hear about all the time. One of the most interesting projects was Finland. They were dying in Finland in the late 60s. Men were dying in their 40s all over the place. Serious and true statement. And a region near Russia in Finland called North Karelia got together a program headed up by a young physician whose name is at the bottom of the slide, Pekka Puska, great name. And they taught the public. They changed grocery stores. They changed recipes to lower the saturated fat in the diet. Less sausage, less cheese, more vegetables, more beans. And the heart disease rate dropped like crazy, 80 to 85%. So they extended the experiment all across Finland, and they found the same thing. But what they found was when they lowered the saturated fat rate, this is the data on the right, not only did all cases of death go down over the course of 20 years, not only did heart disease deaths go down over the course of 20 years, but even cancer deaths went down. So people were eating less animal foods and more plant foods. They did also lower their smoking rates, to their credit. That's always a factor. Amazing study. It wasn't a randomized study. It was a citywide cultural study of teaching people recipes and the rest. How else do we know we might be able to reverse heart disease? Well, there's actually been studies, and you're familiar, but we always have to talk about the plan that a very young medical student, Dr. Dean Ornish, born in Dallas, Texas, for a long time living in the suburbs of San Francisco, designed to ask the question, it wasn't known at the time, if we eat a very low-fat plant-based diet and we exercise and we quit smoking and we lower our stress through group support and meditation and yoga, can we shrink plaque in heart arteries? And rather than guess, he did a study using heart catheterization because they didn't have artificial intelligence, CT angiography back then. Nobody did. But he didn't do just any old heart catheterization. He did use a computer program in Houston to measure it more carefully than is done with patients nowadays, even though this is 1990 data, 1998 data. And this little graph should be hanging in the waiting room of every cardiology office, because the black circles are baseline 1 year and 5 years. How much narrowing is in the arteries of volunteers in the study who did not change their lifestyle? And the white boxes are the results of the narrowing in arteries of people who did change their diet and their lifestyle, the treatment group. And you can see in the control group, blockage got worse and worse, particularly at 5 years. And in the treatment group, it actually totally changed the course and started getting better and better. And this kind of difference, even at 1 year, makes a huge difference in blood flow. People are going to feel better. People are going to pass their stress tests. People are going to avoid going to the emergency room, all of which was shown in this study. Of course, many of you recognize this picture from the book Reversing Heart Disease by Dr. Caldwell Esselstyn, MD, from the Cleveland Clinic. A seriously narrowed artery in 1996, restored to beautiful dimensions with a whole food plant-based diet in 1999. There's no stent, there's no balloon, there's no bypass. Wonderful, wonderful demonstration. Dr. Ornish has similar pictures, but they're in his original publication. So it should be that as of the mid-90s, the late 90s, game over we've proven that we can reverse heart disease with relatively low-cost lifestyle programs that are well tolerated, and they also happen to lower the risk of diabetes, obesity, and cancer. But yet, it took a long time for this to work its way into the American medical system. So that was the 1990s. This was an announcement in 2010 that Medicare decided to pay to educate people who had had a heart attack, a bypass, a balloon, or a stent about the Ornish results, about the results of a famous engineer, Nathan Pritikin, in the Pritikin Longevity Center. And they were going to pay for a program called intensive cardiac rehab, but you had to already have had that heart attack, that stent, or that bypass. Unfortunately, we'd like to move the needle earlier. How about we find disease on a AI coronary CT angiogram and we get insurance approval? There's only one exception where they'll get insurance approval. If somebody's having angina, chest pain, that's stable, then the insurance companies will pay to teach patients how to treat their heart disease naturally and low cost with diet and exercise and recipes and meditation and the rest. So I have patients that do that. Unfortunately, 2010 is 14 years ago, and there are still way too few programs at hospitals that are called the Ornish Rehab Program and the Pritikin Rehab Program. As of now, there is no Esselstyn insurance approved program or Furman approved program, although those are amazing programs. So the key on this slide is the yellow line. There's a little baby up to the left that's got clean arteries, and there's a person with clinical disease in the lower right that has clogged arteries. And we used to say it's hard to see it, but it's a dark black arrow. It just got worse and worse and worse. And now I had to add a yellow line because we can take the soft plaque, which we can measure, and we can reverse it. We can kick soft plaque in the butt. And we need to do it, and we can do it by measuring it, putting in a program, and then remeasuring it, as I've shown you examples. Okay? As we get towards the end, we do agree on a lot. There's food wars everywhere. I've debated all over the place with people. Dr. Dean Ornish was famous for debating people. Dr. Garth Davis has been famous for debating people. But we actually agreed a lot. This is the food plate as suggested by the Physician Committee Responsible Medicine, PCRM. This has been out for over a decade, a beautiful example of eating vegetables and fruits, grains, and legumes. But this is not a plant-based doctor like Dr. Neil Barnard. This is the Harvard School of Public Health. And this is 2011. And what it says on the plate is eat a big heap of vegetables every day, a little smaller but healthy number of fruits every day, whole grains every day, and healthy proteins, which can include nuts and beans as your protein source every day. Drink water, not soda pop. Drink water, not milk. And the Harvard School of Public Health favors olive oil over butters and lard and ghee. You may follow that dictum, you may not. This is this is the Canadian food plate after a big research project. Lots of fruits and vegetables, whole grains, water, not milk, water, not soda, and protein foods. And I sure like seeing some beans and chickpeas, and I see some almonds. I would certainly want to put some walnuts in there. I see that. And I see tofu, and those are the quote unquote protein foods, but I see protein everywhere here. So that's a misnomer, as we know. One more way to kick disease in general in the rear is what I call in my clinic the new executive physical, which is considering and learning about those artificial intelligence coronary CT angiograms. You can arrange to do that in any city in the United States if you have somebody to guide you. But there also are advances in early cancer detection. You can get blood work called a Gallery blood test that can detect cancer early. People are paying to get an MRI of their body to detect cancer early. I did that in February of this year, a center in Miami called Ezra.com, EZRA.com. Consider a DEXA scan to evaluate your body fat and your bone density. Maybe get checked for your heavy metal burden and your genetic makeup. Maybe do an MRI of your brain to see if it's shrinking as a predictor of future dementia, and put in a more brain-friendly food program, fitness program, and other approaches. Take great care of your teeth. Make sure you own a home blood pressure cuff and use it. And if you have any problems with sleep, do a home sleep study. They are so simple nowadays. All right, so I am going to stop sharing, and I am going to turn it back to our wonderful host. I think that was Michael, and see about any questions that there may be, and I'm happy to try and answer them, okay? Let's see.
Yes, thank you so much. So thank you for that. We're going to begin the Q&A session or portion of our presentation. And for any audience members that would like to ask a question, please raise your hand in chat, and excuse me, in Zoom. The instructions for how to do so are in the chat. So we already have a couple of people raising their hands, so I'm going to go straight to the audience real quickly. Bear with me 1 second here. Did you guys just hear me? Because I thought I unmuted myself and it said something of...
Yeah, I heard you.
Okay. All right. Good, good. So we're going to start off with Rita. Rita, go ahead and state where you're from and ask your question.
Good morning. This is Rita Batija from Long Island, New York. Thank you very much, Dr. Kahn, for powerful presentation. I have two questions. How often coronary calcium score should be done? At what point that your calcium score is high? And second thing, Dr. Mark Houston has been mentioning about cardiolipid as far as biotech research to bring down 10% or 20% of LPA little a. So if you have heard about it, but mainly interested in the coronary calcium scale, and also if somebody's LDL levels are high, what about this arterios? I forgot the name that they are talking about. Should one be taking that?
Yeah. Okay, two good questions. I can tell you what I do, because some of these things haven't been researched. If I have a patient that has a calcium score of 0, which again is me, I will repeat the calcium scan, $99, about every 5 years, and see if they're staying as 0. Some of them I don't institute any treatment other than diet and exercise. Some people with crazy, of course, blood pressure, blood sugar, blood cholesterol will still work on that, even though the calcium score is 0. If I have a patient that has a calcium score of 200 or 300, I don't repeat it, because the only thing that happens is it goes up, and it doesn't tell me how narrow the arteries are, and it doesn't tell me how much soft non-calcified plaque. So I will have a discussion with the patient with a high calcium score about going on to the more advanced test, the artificial intelligence coronary CT angiogram. And let's learn the answer to two questions: how narrowed are your arteries, and how much soft non-calcified plaque. I had two patients yesterday morning that I reviewed their artificial intelligence coronary CT angiogram back to back. One was a 65-year-old man whose calcium score was 400, and his artificial intelligence coronary CT angiogram, 80% of the plaque in his arteries was soft non-calcified plaque, invisible on the calcium score. A lot. He had a lot of plaque. He had a lot of blockage. Never would have known it without that test. And we instituted a war on his heart disease, very aggressive approach. The other was a 58-year-old woman, never would have suspected any heart disease, and she, in fact, had a calcium score of only 14, but because of her very high lipoprotein A level and a very scary family history, she wanted that advanced CT scan, artificial intelligence coronary CT angiogram. And she had about 50% of the plaque in her artery was soft, non-calcified plaque. And we instituted a war on her heart disease, a little less aggressive. And some people, it's less than 50% is soft non-calcified plaque. But I don't repeat a high calcium score. There are other doctors that do. I don't think you learn anything because the number goes up. I tell my patients right from the get-go, I can help you with your heart, but I'm not going to make your calcium score go down because there is no proven way to do that. When Dr. Houston, who is a friend and a mentor of mine, talks about that particular agent from a vitamin company, the reality is lipoprotein A varies 20% up and down. That's published data. If you check a person once a week for 12 weeks, it bounces around. Doesn't bounce, 80%, but 20%. So if a supplement drops lipoprotein A 10 or 20%, you'd have no way to know that isn't just natural variation. And studies show the goal is going to have to be to lower lipoprotein A maybe 80%. And the drugs that the pharmaceutical agencies and companies are working on, I have patients that had a lipoprotein A level of 400, and now it's 10 because they're in research studies with these new drugs. They're not supposed to know it's 10. That's supposed to be blinded data, but they're sneaky little patients and they go get their blood tested and they have a little party. I'm getting the real drug. I'm not getting the placebo. So 400 to 10 is, a 98% drop in lipoprotein A. If that proves to be safe, that should be a very powerful effect. The only thing out there that's even close is some people will take over-the-counter niacin, a vitamin B3. And I have many patients that have lowered their lipoprotein A about 75%. That's a big drop, 400 to 100, but that's still not like these ongoing research drugs are showing.
Great.
So at what point would you continue to keep taking the Endocalix or the Vascanox
None of them have any data for reducing plaque. So take them if you want. These are just names of supplements that are very expensive. But ask the question, where is the data that they shrink soft plaque and reduce narrowing in heart arteries? There is no data. They may be working, but there's no data. It's expensive to do the studies. So you just got to work with the person you're working with to see if you're going to use those or not. I'm not saying don't use them. I'm just saying don't believe false promises that they've been shown to reduce heart plaque.
Great, thank you. So regarding the calcium calcium score, what is that actually showing? After speaking to a few doctors, they were talking about it showing healed plaque, like older plaque that had healed and is no longer volatile and at risk of breaking off and causing a coronary event. Can you speak to that?
That may be true. Again, I had a patient, I think Thursday, 39 years old, high cholesterol, worried about it. And the question is, do we get a calcium score on him? Because we know that in younger people, and I would call 39 younger for a cardiology clinic, there may be plaque in the artery, but it may be mainly non-calcified plaque. And it may be that it's the soft non-calcified plaque that's there first. And over time, there's a maturation and maybe a healing, and it becomes calcified. So the thing we're measuring with a calcium score, it's plaque, but it may be a lower risk, older plaque. And what we can't measure is the more worrisome one. So he was aware he wanted to do a $75 coronary artery calcium score. But I did tell him if it comes back 0, we still have to consider other ways like the carotid ultrasound or even the AI CT study. He may have soft plaque, and I've seen that over and over, but that is true. In fact, one of the slides I showed, I didn't emphasize it. There are people that have these super dense spots of calcium. They're called 1000K plaques. And they've been judged to be very low risk, even though they look pretty ugly on the CT scan. It's still atherosclerosis. And I tell you, if you've got a super calcified spot in one spot, you're going to have soft plaque down the artery. So birds of a feather flock together.
So for somebody who moves over to a whole food plant-based diet, and if they have the same outcome as Dr. Esselstyn's patients, and they actually reduce their newer plaque, the more volatile plaque, might they have a high calcium score, even though they're at very low risk for a cardiac event?
Yeah, it's possible. You know, when Dr. Ornish, Dr. Esselstyn, Dr. Furman has a published study and all did those studies, there was no calcium scoring available. And there certainly wasn't this new AI coronary CT angiography. That's only about 3.5 years old. My presumption is when you look at pictures by Dr. Ornish and Dr. Esselstyn, they were shrinking soft plaque. But we don't even have a single case study with this technology to really talk about the specifics. And yes, there's I would imagine if we could turn the clock back and over 5 years in Dr. Ornish's program do calcium scoring, the calcium score went up, but the amount of narrowing went down because the juvenile plaque is what is in play.
And I know these studies are expensive. Do you know if any of that research is underway and being looked at?
Now, I'm unaware of anybody funding. Like, there just was a 1,000-patient study looking at chelation therapy. Cost $40 million to follow 1,000 patients for 4 years. And they didn't have enough money to do calcium scoring or CT angiography. It would have made it a $60 million study. So even some really good, NIH-funded studies can't afford, but we could still have one case study. I mean, that would still be, when I come across a good one, I'll publish it. I have a great case study of a gentleman with a lot of plaque on the AI CT study, said to his doctors in Chicago, no, thank you. And he went off and did chelation for 8 months, intravenous chemicals. He read about them. He was going to clean out his arteries. Went back 8 months later, paid again, did the study. Everything got dramatically worse. So even one case study like that is very provocative. I need to publish that, honestly, because it's so provocative. And if we had, one with a plant-based diet, it would be wonderful, but we don't have one in the literature I'm aware of yet.
So given the expense of these larger scale studies, and you mentioned the power of a case study, what would make how would you design a case study so that it could be reliable, so that so that way it could be not a substitute, but an alternative to these larger, more expensive studies that tend not to get ever done?
Yeah, you'd have to get a statistician involved and say, there's enough examples now of people who had these artificial intelligence CT angiograms and had another one in a year that you could say, we can see 40% reduction in plaque in a year, which you can. If we just had 10 patients in a study, 5 adopted Esselstyn, 5 stayed on the American Heart Diet, we might have enough to make some kind of statement. But the statistician would help us estimate, no, you need 40 in there. And of course, then the costs are 4 times as high. I would think if somebody had $1 million, you could do this study.
And with the nature of eating food being challenging to do like a double-blind study, are there limitations to that? There's this idea that a double-blind, placebo-controlled study is the gold standard, but in some things, like specifically with food, it is impossible to do that. Is that really a limitation?
Right. You can do double-blind studies with drugs. You can do double-blind studies with aged garlic tablets because they are odorless. But it wouldn't be a double-blind study with food. It would be what Dr. Ornish and Dr. Esselstyn's wasn't randomized. Dr. Ornish was. But you really got to have people on the phone calling these subjects and, reminding them how you're doing today and where you're running into trouble and how you're doing in restaurants, how you're doing at work. And let me give you some solutions. And sure, all nutritional research is tough. And, there are 2 Spanish studies that stand out. The PREDIMED study had 7,000 people for about 7 years, randomized to 2 versions of the Mediterranean diet. But that study, very powerful study in cardiology, was actually accused of some fraud and had to be republished, and it's tough. And then there's one in Spain called the CardioPrev study. I've talked about that last year at this conference. And that's 1,002 heart patients that randomized to 2 different diets. But boy, they're calling these people all the time to keep them on track. And that's a high olive oil versus a low olive oil Mediterranean Spanish diet. And the olive oil group did better, as I talked about last year.
And if I understood you correctly in your presentation, you were talking about saturated fat perhaps being the real culprit as opposed to dietary cholesterol. Was that
Right.
And so to that extent, might one's cholesterol really be an indicator of how much saturated fat they're eating, because cholesterol, the foods that cholesterol comes in tend to be high in saturated fat also.
Right. And that's correct. There's two reasons your cholesterol can be high. There's more. I mean, if you have thyroid trouble, liver trouble, and the rest, but predominantly it's how much saturated fat is in your diet, which is largely animal foods, and it's genetics. There are many dedicated plant-based eaters with high cholesterol, and they are just producing too much cholesterol. There's a $99 little finger poke blood test. You can find out if you are genetically a hyper producer of cholesterol. And many plant-based people and many people in general are, and they're frustrated. You know, they see these great examples on websites of, you know, people losing weight and their cholesterol dropped dramatically. Well, you can lose weight, but sometimes the cholesterol won't drop. So I set up realistic goals for patients because they're not all going to hit great numbers. The other thing, just to share with the audience, is in somebody with established heart disease, we used to talk about the goal was an LDL cholesterol less than 100. And a lot of people could do that with whole food plant-based diets. But now we're pushing their LDL under 50. These are established heart attack, bypass, stent patients. It's very hard to get your LDL under 50, even with, you know, a no salt, oil, sugar version of a whole food plant-based diet. So unfortunately, the use of prescription drugs is going to remain an important component, and maybe even more important now that we have these CT angiograms and we see all this god-awful plaque. My patients go right to lifestyle, fitness, supplements, and they'll accept drugs when they see the data. And I think this is transformative. I think this is fine. You know, of course, we watch for side effects.
And if people, so you mentioned the genetic component to cholesterol. If people are doing everything right, they're eating the whole food plant-based diet, and they have no signs of coronary artery disease, except their cholesterol is high, like above 200. I don't know. And if you can speak to the range that someone might find themselves if they have a genetic predisposition to high cholesterol, what that range might be. But if they do have a high number, but everything else looks good, should they still take a statin?
Yeah, that is a controversial topic. I have, you know, 100 patients with a cholesterol of 250. They actually all have a calcium score of 0. They have reasonably good inflammation blood tests. They're not smokers, they're not diabetics. What happens 30 years later if we put half of them on a statin and half of them we didn't? And if we had a room full of cholesterol experts, we'd have a split in the room too. Some would say, you're fooling yourself. They look good now at age 46, but what are they going to be like when they're 76 if they keep their cholesterol that high? And one option is every 5 years, get the calcium score, see if they stay at 0. Every few years, if you have access to it, do the carotid intermedial thickness plan. That's what I do with myself. I don't have a cholesterol 250, but it's slightly over 200, despite a very plant-based diet for 45 years. But I keep an eye on everything. That's why I had my carotids checked Thursday morning, 2 days ago. And the first, you know, signs that things are starting to age, I'll consider what the next step is. It might be a supplement rather than a prescription drug. But there's a debate there. And unfortunately, it's a 30-year debate. I told you, you can cut a breast cancer out and never have breast cancer again. We don't cure atherosclerosis. We can stabilize it. We can put it into remission. And the bottom line is not everybody gets atherosclerosis. My favorite is a 89-year-old woman in my clinic a couple of years ago. She's now 94. And she insisted on a calcium score. Mainly, she was so certain she was a 0. She had been doing the Pritikin program for 50 years. And she was a 0 at age 89. And there's probably people older than that are a 0. So not everybody gets atherosclerosis. But boy, don't assume you're like she is. She did the test and found out.
Thank you. And what advice do you have for the medical professionals who are skeptical about integrating plant-based nutrition into their practice?
Don't be skeptical. My standard is, you know, I have a wonderful clinic, but I don't employ a dietitian. I know a few in town and a few nationally that will, you know, consult by Zoom. But I have a pre-printed list, Forks Over Knives, What the Hell, Game Changers movie, now the new Netflix, You Are What You Eat. Maybe read my book, The Plant-Based Solution, or Undo It by Dr. Ornish or Dr. Esselstyn, or I love Dr. Furman's books. Read a book on plant-based. I'm amazed 6 weeks later on follow-up how much change they've made. Some have gone plant-based, crazy. And all they did was, spend a few hours on the couch watching some documentaries. Now, if that doesn't work, I'll refer them out. And then there's the group that won't change no matter what. Obviously there are people who've had heart attacks and still smoke, and some of that's addiction and food addiction. Some of it's just stubborn psychology, and it's very frustrating.
So, there's all these different plant-based doctors, and they all have variations of what you should do, how much you should do in supplementation. Some say, don't worry about supplementation other than B12. Others are suggesting supplementation, ad nauseum. Is there anyone that you think whose protocol has been verified by their outcomes? And are we getting lost in the details when we should be focusing on the whole food plant-based part, and then the other things are just more tweaking, or are those dramatically important?
Yeah, I've been formally educated in supplements. I spend a few hours a week reading medical literature on supplements. I don't have my own supplement line. That may change, but at this point I don't. I use supplements, but I have to chuckle. I listened to a podcast this week on the topic of treating high blood pressure naturally. And the doctor being interviewed, he was a naturopathic doc, and they're wonderful people. But he was talking about people leaving the office with like 14 new vitamins on the first visit. I won't do that. I insist that generally there has to be science behind the supplement. So I showed aged garlic supplements. There's 10 studies, 20 studies, 30 studies in humans of advantages to blood pressure, cholesterol, homocysteine levels, and actually to plaque. So I use that in almost every patient. So I actually think, with all humility, I have the most advanced protocol for supplements, because the first questioner mentioned a couple, and I'm very familiar with them, and they're available, but I need to see a study before I'm going to ask you to spend $100 a month, or maybe buy 2 supplements that are each $100 a month. I mean, those costs add up. So I'm sticking to a few that have science. I'd rather you be consistent and take them.
So you mentioned this naturopath suggesting 14 new supplements. And while they can point to research for this supplement working on this specific issue, and that supplement working on another issue, how do we deal with the risks of contraindications between a mix of 14 different supplements when the research hasn't been done, because we can't even get the most basic research studies done?
Yeah, and there is some risk to that. People genetically are different and metabolize different and absorb differently. People take vitamin D and don't have good blood levels, and people take vitamin D and do, and there's differences in absorption and receptor density and all. So it gets very complex. And the other factor is, and I see it all the time, people get pill fatigue, and if you can get them on 1 or 2 necessary prescription drugs, these are real heart patients, and 1 or 2 or 3 supplements, and then they're probably going to be taking a baby aspirin a day. Some people take a natural blood thinner called nattokinase rather than a baby aspirin a day. If it's 6 to 8 pills a day, they may be compliant long term. But I see people all the time that were taking 30 vitamins, and they just give up and they take breaks, and that's suboptimal. So I think you have to be real life reasonable too. The other thing is, many of the drugs are generic and cost pennies a day. Aspirin is pennies a day when indicated. Not everybody needs aspirin. You can make a $500 a month supplement bill very easily, and that's just not sustainable for most people.
So you mentioned baby aspirin. What's the latest research on baby aspirin? I believe there was some research that came out that suggested it may not be as safe, or there may be problems with patients taking baby aspirin.
Maybe good question, maybe 3 answers. Until 2018, there was an old school practice. Joe or Jane, if you take a baby aspirin a day, you'll lower your risk of stroke or heart attack. Just add it in. Maybe their cholesterol was up, maybe their blood sugar was up. In 2018, 3 very large studies, I think they included total about 40,000 patients, were randomized. These are healthy people without heart attack, to aspirin or placebo, and none of the 3 convincingly showed that a baby aspirin a day added to a general program had a convincing risk reduction. Or if they did lower risk, there was a GI bleed risk that was almost the same. So there were all kinds of headlines, and they still show up now and then. Very importantly, those 3 studies excluded people with stents, bypass, heart attacks, because we never questioned whether they should be on aspirin, and we still believe they should be on aspirin. So now we are in 2024, and since 2018, 2 very large studies have been published that if you get that coronary artery calcium test, and if the results are over 100 abnormal, you can show a benefit on average by taking a baby aspirin a day. And that's what I tell my patients with the high calcium scores. Get back on aspirin. The studies do suggest it. We don't have specifically data what to do with that artificial intelligence coronary CT angiogram. But if there's a lot of soft plaque, if they're a stage 2 or higher patient, I'll put them on baby aspirin. The final answer is one new group. There's a study about 2021 and a study just in the last month that if you've inherited a high level of lipoprotein little a, more than 125 nanomoles per liter, so we're talking, 15 to 20% of the population, taking a baby aspirin a day may help prevent stroke and heart attack. So that's something new. I wasn't doing that before. And if people say, well, I'd rather take nattokinase, which is a little bit more expensive vitamin that thins the blood, I'll work with them with that. But I'm going to ask them to take something.
How do you respond to critics who argue that moderate consumption of animal products is not harmful to the heart?
Well, it's harmful to the animal and it's harmful to the environment. We got lots of data. But this question comes up, Doc, 2 eggs a week. I mean, it's what John Mackey, the founder of Whole Foods and a plant-based advocate, says. It'd be very hard to show that a 90% plus plant-based diet and 100% plant-based diet have a seriously different outcome on people, because so few people eat that well already. That would be such a great advance. I think the sicker you are, the heavier you are, the more your blood sugar is an issue, blood pressure is an issue, inflammation is an issue, sleep apnea is an issue, and heart disease is an issue. The more the 100% goal is important. And the second thing is human nature. It's people that are creeping. They creep away from taking their vitamins. They creep away from taking their prescription drugs. And they creep away. They get all excited when they watch Forks Over Knives, as an example. In the year follow-up, I added back some fish and a little chicken, and then I really get what they're eating. And they told me they were plant-based, and, maybe it's better than they started, but boy, have they wandered. So, I find it easier. And again, I've been doing whole food plant-based for 45 plus years, strictly 100%, never an animal product. It's just easier. The rules are so clear cut, and the availability of food is so wide that nobody's going hungry being 100% plant-based.
And on that point, with regard to it being easier, I heard an expression with regard to addiction that 99% is hard, 100% is easy. So
yeah, I generally agree with that. One drink can get a person back, one cigarette can get a person back, and one Krispy Kreme donut, man, that can, particularly for a food addicted, sugar addicted person. So I do find, I often say, be extreme in diet, moderate in exercise, and abundant in love. That's my own little triad there. So take that home.
So with people who are food addicted, which I think is probably most people in the United States, should we look at ourselves like alcoholics look at themselves, that somebody who stopped drinking for 20 years is still an alcoholic, and if they have a drink, it's dangerous? So if somebody who had, unhealthy practices and really overconsumed food uncontrollably, and they've been good for a long period of time, they should really avoid that Krispy Kreme donut or any product like that, because they're still a foodaholic?
Yeah, well, there's a subset that's definitely true. I mean, I have patients and friends that sugar is their nemesis, and it has to be 100% rule, and it can be 10 years later. And, it's probably different when you talk about, drinking a liter of vodka versus having 3 or 4 Krispy Kremes, but that may trigger them, to really slide. And, it's an addicted brain, and they're going to have to go through the whole process of withdrawal again. So, they know their guidelines and they're very careful about it. It's sort of like a celiac patient, they're not casual about gluten. They know they're going to have diarrhea and bloody diarrhea, so they're strict. And or a nut allergic patient. There's plenty of people out there being 100% compliant. So yes, and the other problem is we cut out and cure prostate cancer. We're not cutting out and curing atherosclerosis. So 20 years later, they've got more atherosclerosis than they had 20 years earlier. And it's just as important, I really insist on my patients. I have a lot of them, but I got to see them at least once a year. I got to, remind them with either a baseball bat or, a loving hand that this is a long haul. And, they don't want to be a demented 86-year-old, and nutrition and fitness is part of dementia, just like it's part of heart disease.
Thank you. I'm going to throw it to the audience. Joe L., please state where you're from and ask your question.
Yeah, Huntington, Long Island. I have 3 quick questions, but you can take your time because I did subscribe so I can go back to the reruns. And I advise everybody to subscribe to the reruns of the conference. My first question is, would calcium, a calcium deposit in my kidney show up in a calcium test? My second question is, I grow vegetables, and I have quite a bit of garlic in the ground this year, and they're doing great. How do you suggest I age garlic? Because I love what you said about, some of the studies on aged garlic and blood pressure. And the last thing is, I have 2 beautiful kids in their 30s, early 30s, and they're both outstanding and successful sports trainers, and they're obsessed with animal products on a daily, minute-by-minute basis. Right. And I need to stop talking about it and get them in a doctor and get them tests. What tests do you advise young people to do, right, to be able to wake them up to what's happening?
Okay, real quick. First question is a real good one. You can have a CT scan of your abdomen for a kidney stone, and the report may mention calcification of your blood vessels. That is a big clue everybody ignores. Don't ignore it. I always read the report. It's one little line in a long report. I want to know. Number 2, a lot of people get a chest CT scan for pneumonia, for a cough, for fluid. They'll often mention that the aorta and the heart arteries are calcified, just as a comment. Don't ignore that. Read the study. And if the radiologist doesn't mention it, I'll tell the patient, get me a copy of that CD and I'll look at it. And we get free information. But more and more radiologists do mention it, and they should mention it. And then even the dentists are doing x-rays of the mouth, and they'll send me a patient. They see calcium in the carotid artery. So it's a disease-wide. You can have a CT, you can have an x-ray or a CT of your knee because you twisted it and the blood vessels are calcified. They're all clues. They're all disease and shouldn't be ignored. Number 2, you're going to have to look up online, how long do you leave a bulb of garlic out? I believe when we're talking about these tablets, it's 2 years. So it's a long process. And whether that's practical or not, I don't know. And the third is, have your kids read a book like Plant-Based Athletes by Matthew Frazier and Robert Cheek. Great book. And, blood tests. They should know their fasting cholesterol, their fasting blood sugar, their C-reactive protein. They should know their lipoprotein little a. A lot of people are doing, this terrible animal-based diet because there are doctors out there saying if you want to build muscle, you have to eat flesh and eat muscle. And it's crazy data. I mean, you can do it with edamame and lentils, but their cholesterol may be sky high. Again, this young 39-year-old I saw on Thursday, That was the keto diet, because he's an athlete. His cholesterol is crazy. I gave him a 4-week plant-based diet and challenge, and I was surprised. He said, I'm going to do it. I'm going to see if I can drop my numbers. I don't want to be on a drug. So, get them tested.
Thank you.
So, and for people who are interested, we had a speaker named Derek Treesize.
Yeah, great guy, Derek Treesize.
Yep, and he's a trainer and a professional bodybuilder, plant-based, and tested multiple times for competitions that he's all natural. He's got a tremendous amount of muscle, and he can speak to and had speak to that idea of putting muscle on as a plant-based athlete. So the next question is coming from Janet M. Please state where you're from and ask your question, Janet.
Yes. Hi, Dr. Kahn. First of all, thank you so much for your presentation. I'm from Maryland. What I wanted to know is, of all your books or articles or pamphlets, like, is there one that kind of concisely in a few pages would have the different tests that you're talking about and sort of the progression of tests? Like if you have a high calcium score, then go to this test, and also that would list the supplements, like something just concise in a few pages that one could buy from you?
Yeah, well, I actually give it away for free. On my clinic website, Kahn, Kahn, longevitycenter.com, there's a button for blogs, articles, and I write an article every week. And in about July 2023, I just doing it from memory, I have a blog called What Do I Do About My High Calcium Score? And it's the longest blog I've written. It's maybe 8 pages, but it literally has step-by-step what to do. And there are links to the research articles, because as I said, if the science isn't there, I'm guessing, and I don't want to guess with my patients.
Thank you. And we've got about 3 minutes left. So in the beginning of the presentation, you started with the idea that people seem to be focused on the wrong things based on their search. We know what the #1 killer is in the United States, and yet cancer has a much higher search rate. In trying to understand why that might be, I'm curious how much money is made in the treatment of heart disease versus the amount of money made in the treatment of cancer.
Yeah, and it's a good question. Much more with cancer, I'm not saying it's unnecessary, but there are chemotherapy drugs that are tens of thousands of dollars a month. If you have a bypass surgery or a stent, you're going to get a hospital bill for tens of thousands of dollars. Hopefully your insurance will cover most of it. But, right now, our most expensive cardiac drug is about $700 a month, $800 a month. And, it's a big struggle for a lot of people if we can't get insurance coverage. We're nowhere near like cancer. So is it true that some of the reason it's being driven by the pharmaceutical industry because it's so lucrative in the oncology world? Yeah, I think that's likely and true. Nobody promotes the doctor's lifestyle and diet and fitness and generics and supplements and sleep therapy because it's a loser. Calcium scoring is a loser. Do you think anybody makes money on a $75 CT scan? And there's a little money to be made on the $1,500 coronary CT angiogram. But the good news is we can actually get a lot done at a low cost. So that's why I can get most of my patients. I'll tell them, you're getting the same test Elon Musk and Jeff Bezos get, and they'd pay the same amount, but you can have the same care.
Thank you. So we've got about a minute left. If you could leave us with any final thoughts for the audience, and I'd like to leave on a positive note on how you see the future unfolding.
Yeah, I think the current way we treat cardiology patients is so exciting. This is my 35th year in practice. I could retire. I'm so excited. I'm not. I get fired up, working with people. We've opened this door of visibility of staging you in this war against heart cancer and fighting it. And maybe you don't have it at all, which is also the good news. So, just don't assume that you're healthy because you look good on the outside. I hope you are, but let's find out. And let's have a conversation in 5 years where we've seen heart disease drop. Certainly in this audience, hopefully across the entire United States.
Great. Thank you for all the information you shared with us today, Doctor. If we could unmute the audience, please.
Thank
Thank you.
Thank you.
Dr. Kahn. You're the best.
Oh, no, no.
A lot of
Amazing.
information. I love
We
your
love you.
book.